Kidney stones. Now let's shift from renal function to kidney stones or nephrolithiasis. Stones form when the concentration of solutes in urine exceeds their solubility, leading to crystal formation. And these crystals can grow, aggregate, and obstruct urinary flow, causing severe flank pain, hematuria, and sometimes even infection. The composition of the stone, whether calcium oxalate, uric acid, struvite, citrulline, or cysteine, can tell us a lot about underlying metabolic disturbances. Understanding the type of stone helps us guide both prevention as well as management. After a patient passes their first kidney stone, the approach to evaluation will depend on risk and recurrence potential. This is like, do we catch them or do we not catch them? What is the question? For most patients, a full metabolic workup after a single episode is not necessary, and it's actually not cost effective for the patient. However, we do want to identify any obvious risk factors: dehydration, dietary issues, systemic conditions like hyperparathyroidism. And then for patients who maybe are more frequent stone formers or have bilateral kidney stones present, a more complete metabolic evaluation is indicated to prevent stone reoccurrence. So if we're doing a limited evaluation, this is fairly appropriate for most first-time stone formers. We would start with a basic chemistry panel to assess calcium, bicarb, and renal function. Elevated calcium on two occasions may suggest primary hyperparathyroidism. Low bicarb can indicate renal tubular acidosis or even chronic diarrhea. And if serum calcium is high, parathyroid hormone should also be checked. A urinalysis is essential as this can provide information about urine pH, possible infection, and the presence of crystals or blood. Urinalysis findings give us important diagnostic clues to the type of stone and the condition of the patient. A pH that's greater than 7.5 suggests a struvite or calcium phosphate stone, while a pH below 5.5 would favor uric acid or cysteine stones. Calcium oxalate stones, the most common type, aren't really pH dependent. Examining urine sediment can also reveal specific crystals, hexagonal cysteine crystals, or coffin lid shaped struvite crystals that point towards specific stone types. And remember, calcium oxalate crystals can appear in healthy individuals, so we need to, apply that clinical context. About 70 to 80% of all kidney stones are composed of calcium oxalate, as I mentioned, or calcium phosphate. Hypercalciuria, or high calcium excretion, is a risk factor for these patients. Calcium oxalate stones often form in more acidic urine, while calcium phosphate stones tend to form more in alkaline urine. Factors like low urine volume, dehydration, and high dietary oxalates also can promote stone formation. And these patients would benefit from increasing fluid intake, moderating sodium and animal protein consumption, and ensuring balanced dietary calcium and balanced oxalate consumption to make sure that we're not pushing a pathway too far. For our recurrent stone formers, a complete metabolic evaluation is recommended. This will involve two separate 24-hour urine collections where the patient is on their normal diet, typically a few months after the stone event. In this, we measure calcium, oxalate, uric acid, citrate, sodium, creatinine, and pH. Low urinary citrate, called hypocitremia, is a common abnormality that increases stone risk. These results can help tailor our prevention plan for patients and also help promote specific dietary strategies or adjustments, even medications to reduce calcium or uric acid secretion. A 24-hour urine calcium test can quantify the calcium excretion to assess for hypercalciuria. In our AMAB individuals, values above 300 milligrams per day, and in our AFAB individuals, values above 250 milligrams per day suggest excessive calcium loss. Hypercalciuria may be due to conditions like primary hyperparathyroidism, vitamin D excess, or bone reabsorption disorders. Conversely, hypocalciuria can result from vitamin D deficiency or renal failure. This test helps differentiate the metabolic causes of nephrolithiasis and helps us guide treatment for any calcium-related stone risks. This test can also help determine the cause of, besides a recent kidney stone, it can also point towards other pathologies like primary hyperparathyroidism or even sarcoidosis. While if there is a decreased calcium, that could suggest malabsorption or hypoparathyroidism. Blood calcium is often checked alongside to provide us some context clues, so we're not just looking in the pee. And remember that urinary calcium excretion will depend on diet. So it is important to get a dietary diary for these patients and understanding patients' intake. Clinically, it is one of the most helpful tests for evaluating metabolic contributors to stone disease. When interpreting these results, always think in terms of cause. Increased calcium levels can occur in conditions like primary hyperparathyroidism, vitamin D excess or toxicity, bone reabsorption disorders like osteoporosis or metastatic cancer, corticosteroid therapy, Cushing syndrome, or even sarcoidosis can contribute. On the other hand, a decreased calcium excretion could be seen in some opposite conditions like hypoparathyroidism or vitamin D deficiency, calcium malabsorption, or advanced kidney failure, renal failure. This distinction will help to guide whether calcium abnormality is renal, endocrine, or nutritional in origin. You can also do a 24-hour oxalate test, which measures the amount of oxalate excreted in the urine over 24 hours. Oxalate originates partly from the diet, about 10% from vitamin C metabolism and from amino acid metabolism, particularly glycine. High oxalate excretion increases the risk of calcium oxalate stones. And some individuals absorb and excrete more oxalate due to genetic or intestinal factors. Increasingly, a low calcium, or interestingly, actually, a low calcium diet can worsen hyperoxaluria, high oxalate urine in the urine, because there's less calcium to bind oxalates in the gut. This allows for more to be absorbed and then more to be excreted. So we would consider this test in patients with recurrent calcium oxalate stones or those with a GI disorder that affects absorption, like Crohn's disease, celiac disease, a history of ileoresection. They could all lead to increased oxalate absorption. Bariatric surgery, particularly a jejunal bypass, is another cause. And in these patients, fat malabsorption allows free oxalate to bind poorly, leading to increased urinary oxalate and stone formation. So this test is essential when evaluating nephrolithiasis in patients, specifically with a GI pathology. Here are some normal values to consider. They vary based off of sex and age. Typically, our AMAB individuals are going to have a little bit of a higher range, and then AFAB individual a little bit of a lower range. But the goal here is not to memorize these numbers, it's to be able to recognize when a value is significantly elevated, as hyperoxaluria is a major risk factor for calcium oxalate stones. And this kind of can tie us back to our naturopathic principles of treating the underlying cause and starting at the foundations of health, because we would probably target this initially with dietary strategies to try to reduce oxalate intake. So if you have an elevated or an increased oxalate excretion, it could be due to ethylene glycol poisoning, which produces calcium oxalate crystals in the urine. Genetic disorders like primary hyperoxaluria leads to overproduction of oxalate. Liver diseases, pancreatic disorders, pyridoxine deficiency, vitamin B6 deficiency, and celiac disease can also all elevate levels. Decreased oxalate excretion typically reflects impaired kidney function, so renal failure. And recognizing these patients can help us identify whether it's metabolic, dietary, or toxic in origin. Our hypocyturia, essentially low citrate in the urine. So citrate is a natural inhibitor of kidney stone formation. And so when urinary citrate levels fall below 500 milligrams per day in AFAB individuals and below 434 milligrams per day in AMAB individuals, the risk of calcium-based stones is going to increase. Chronic metabolic acidosis seen in IBD, malabsorption, and renal tubular acidosis can reduce citrate excretion. A high protein diet and acidosis both drives calcium and calcium to release actually from even bone while reducing citrate buffering in the urine. So counseling patients to increase fat, fruits, veggies, and even fluid intake can restore balance and reduce these reoccurrences. Uric acid is the final breakdown product of purine metabolism, and it's produced mainly in the liver. It's excreted primarily by the kidneys. I have normal ranges listed here in milligrams per day. Elevated uric acid excretion can contribute to gout and uric acid stones, and this is particularly when urine pH is low. 10 to 15% of stones in the kidney are uric acid based. A high purine diet, metabolic syndrome, and obesity are all increased risk factors for uric acid levels going up, making dietary management actually an important part of prevention. A uric acid stone can form in acidic urine, typically with a pH below 5.5, and in states of hyperuricosuria. They're more common in patients that do have concomitant gout. And because they also could be seen, though, in insulin resistance or even obesity. Because uric acid solubility increases with higher pHs, treatment often focuses on urine alkalinization with citrate or bicarbonate, and these stones are radiolucent on X-ray, so CT or ultrasound is needed to be able to see them. Identifying these patients early on allows for both dietary and pharmacologic intervention to reduce stone formation. Increased uric acid excretion or uricosuriia can occur in gout, as I mentioned, leukemia, myeloma, or even following chemo due to rapid cellular turnover. It also can result from excessive intake of purine-rich foods or even lead toxicity. Decreased uric acid excretion is often seen in renal disease, eclampsia, or chronic alcoholism. When interpreting results, always consider both serum and urinary uric acid levels. High serum with low urinary excretion suggests undersecretion, while high in both reflects overproduction or dietary excess. Triple phosphate crystals, which are also known as struvite, are composed of magnesium, ammonium, and phosphate, and they typically form an alkaline urine and are most common in our AMAB individuals. These crystals are associated with urinary tract infections by urease producing bacteria, Proteus, or Klebsiella. When infection persists, these crystals coalesce into a large staghorn calculi that fills up the renal pelvis. So you need to treat both the infection and the underlying urinary environment to prevent reoccurrence. And these stones are often damaging to tissue. When evaluating a patient with nephrolithiasis, we take a stepwise diagnostic approach. First, stone analysis is critical. Knowing the stone composition helps identify metabolic causes. Serum studies, including calcium, parathyroid, hormones, vitamin D, and electrolytes, can help uncover systemic abnormalities. A urinalysis checks for pH, infection, or crystals, and urine culture rules out infection-related stones. A 24-hour urine collection provides detailed information on volume, calcium, oxalate, citrate, sodium, uric acid, and cysteine levels. And finally, a non-contrast helical CT scan will remain the imaging gold standard for detecting stones and obstruction.